Good afternoon, everyone. I'm Patricia Dorsey, Meetings and Education Coordinator here at America's Essential Hospitals. Thank you for joining us today and welcome to America's Essential Hospitals webinar, Managing Medicaid Lives with Provider Service Networks. Before we get started with today's presentation, I would like to call your attention to the webinar section of our website. We have many webinars currently open for registration, so we encourage you to visit our website and register to join us for any or all of the offerings that are of interest. Today's webinar is being recorded and will be available on our website by the end of the week. To download today's slide deck, please refer to the chat box located on the right side of your screen. To ensure that you can interact with us today and utilize the chat feature, please make sure you have selected both the participant and chat tabs on the right-hand side of your screen. Your lines are currently muted, but we'd still love to hear from and interact with you. We will address questions after our speakers have concluded their presentations, but please feel free to share and discuss what's on your mind or ask questions in the chat area at the bottom of the screen anytime throughout the webinar. If you prefer to communicate telephonically, please use the raise your hand feature at the bottom of your participant panel to indicate to me that you wish for me to unmute your line. I will then announce your name and ask you to proceed with your question or comment. Here's a screenshot from our webinar vendor, WebEx, that again shows the chat box and participant panels. Pressing the hand icon at the bottom of the participant panel will raise your hand. We have some exciting speakers today. I will now turn it over to Seth to begin the presentation.
Great, thank you so much, and good afternoon, everyone. I hope you're doing well, and for those of you that maybe are in Florida or in the path of the hurricane, I hope you are hunkered down and safe. Really excited about today's webinar. We are going to spend a little bit of time going over the exciting partnership that America's Essential Hospitals and Premier has put in place related to our value-based care collaborative. So we're going to spend some time talking about the collaborative, its goals, and how it works, and what the potential value could be for your organization to participate. We'll then spend the majority of our time with Jessica Lerner, who's the President and CEO of Community Care Plan, which is a provider-owned plan that's jointly owned by Broward Health and Memorial Healthcare System down in Broward County, Florida, about the work that they're doing related to managing their populations. Really, just on a personal note, I've had the pleasure of working with Jessica and the team down at Memorial Healthcare System for 9-10 years now, and they've been doing some really incredible work that I'm hopeful will provide you with some great overview of how they're managing populations and how they've been able to be really successful in working with the Medicaid, uninsured and underinsured population. But first, before we get to that, I do want to take a little bit of time just to make you aware of the offering that we've developed for the Essential Hospitals Value-Based Care Collaborative. For those of you that aren't familiar with Premier, we are a performance improvement organization. We work with mostly hospitals and health systems from across the country. Right now we work with about 3,900 hospitals and about 150,000 other providers and organizations to do a number of different things. Work on performance improvement related to supply chain efficiency, but then more specific to what we're talking about today, to help organizations manage their transition to value-based reimbursement. We have a number of different collaboratives that we offer in conjunction with that type of work. We have a Quest collaborative, which is a nationally awarded, they received the Eisenberg Award a few years ago to help organizations drive inpatient success on the inpatient value-based purchasing programs. We have population health management collaboratives that are focused on helping organizations implement and drive performance improvement around population health models. We have bundle payment collaboratives as well that help organizations with the new bundle payment models that are out, the oncology care model, the comprehensive care for joint replacement model, as well as the new bundle payment for care improvement initiative. But what I'm here to talk about today, as I mentioned, is the Essential Hospitals Value-Based Care Collaborative. You can see on the slide the overview of the core purpose of the collaborative, which is really to help your organizations drive success. And by success, we mean a multitude of areas. Getting shared savings, driving internal efficiencies to improve margin, improving quality outcomes related to specifically Medicaid, the uninsured and underinsured population. But we also recognize that to be successful, health systems have to put in place holistic approaches across payers to implement these capabilities. And so I think the unique nature of this collaborative is while we have a focus on Medicaid, uninsured, and underinsured populations, we also provide support for employee health plans, Medicare fee-for-service. We work with about 52 Medicare ACOs in the Medicare Shared Savings Program and the Next Generation ACO model, also in the Medicare Advantage space, commercial employers, and direct-to-employee contracting. So we use the collaborative to focus really across the various payers, and then we also try to look at different capabilities that are payer agnostic. So how can you leverage care management across payers to drive internal efficiency and to really manage those populations? So that's really the core purpose of the collaborative. And the reason that we took that approach and really focus across payers is that we recognize that this transition to value-based reimbursement and value-based care models is something that requires pacing. You don't want to get out ahead of, if you're implementing these care redesigns, you don't want to get out ahead of your payers. But conversely, you don't want to have contracts with payers if you do not have the internal infrastructure in place to be successful. And so really looking at across the health system, across your hospitals, you're taking a holistic approach to your payers, and then understanding what are the internal capabilities that you need to have in place to manage those populations and to ensure success related to quality outcomes as well as the improvement of cost and the improvement of the patient and caregiver experience is what we try to help organizations do. And what you'll see is that through this collaborative, we put in place kind of a five-pronged approach to be able to do that. The first is one-on-one support, and we'll go into a little more detail about all of these in a moment. The second area is education and best practice sharing, as well as those population-focused cohorts, which I mentioned a moment ago. The third is learning, exchange, and peer networking. The fourth is subject matter expertise. And then finally, leveraging the power of the collaborative and all the organizations that we bring together that are doing really creative, innovative work to develop insights and to scale innovation. So helping organizations stay on the leading edge and not having to reinvent the wheel. The way we do this in the collaborative methodology is really through a three-pronged process. And this is something that we've tested broadly. We started with the Quest Collaborative, which was that inpatient value-based purchasing group, and have really rapidly scaled it and applied it across the various collaboratives that Premier has in place. The three pillars of this methodology are the idea of connecting people, connecting data, and connecting knowledge. So for connecting people, it's the idea of bringing together organizations who are engaged in a similar journey, have similar experiences to learn from each other in a collegial and transparent manner. The example that we use and what I think the value of the Essential Hospitals Value-Based Care Collaborative is that it's being operated in unison with our Population Health Management Collaborative. So members of, if you were to join the Essential Hospitals Value-Based Care Collaborative, you'd have access to not only everything that's going on within that group, but also Premier's Population Health Management Collaborative. And currently within that group, we have over 75 health systems and clinically integrated networks that are participating across a large number of different payers, a large number of different geographic areas, and have different experiences to share and to learn from. The second is connecting data, and so we at Premier are a Baldrige company. We believe in continuous improvement, and that continuous improvement has to be on the back of a data-driven approach. So within our collaboratives, we set up mechanisms to take in data. In the Medicare fee-for-service space, we bring in claims data. For employees and in commercial space, we do manually reported aggregate level data. And for the Essential Hospitals Value-Based Care Collaborative, we are working on developing the ability to get Medicaid data in to use this information to, one, benchmark performance so we can see what's attainable, and then use that data to drive enhanced facilitation of networking. So the example that we use from the Population Health Management Collaborative is we'll look at organizations' claims data, we'll see where they have opportunities, we'll look at the transparent benchmarking and identify who within the collaborative is doing really well with that opportunity, and then we'll set up direct one-to-one conversations so they can learn firsthand how those organizations have achieved high levels of performance. The third pillar is the idea of connecting knowledge, and this is where you have the ability to leverage a lot of the work that's been going on within the Population Health Management Collaborative, which is a very mature group. We've been operating for over 8 years now and have developed a large number of toolkits, guidebooks, assessments, and other activities to really drive efficient uptake of value-based care capabilities to implement within your organization. Moreover, I'm a member of a team of about 65 individuals who have expertise all across the continuum. We have former CEOs who have led health system transformation. We have clinicians who have led clinical transformation. We have people like myself who have a healthcare policy background, and use that to drive strategic decision making. We have people who focus on performance enhancement and improvement and leveraging data to do modeling. We have lawyers and everything and anything in between. And so leveraging our expertise, leveraging the experience of other organizations, and leveraging data to drive performance improvement has really been a mechanism for success for our group. And we'll talk a little bit about the outcomes that we've been able to achieve. Specific to the Essential Hospitals Value-Based Care Collaborative, this slide outlines some of the key objectives that we want to put in place. So you can see here the idea is to provide a payer-agnostic approach to value-based care with an emphasis, though, on the Medicaid, uninsured, and underinsured populations. And so what we want to do is provide strategic recommendations through an assessment tool that you have available to you annually that incorporates your unique evolving environment to help you navigate the changes that are occurring. We also leverage the collaborative methodology to accelerate dissemination and effective implementation strategies. Really, our goal is for you to have as efficient and effective of a process as possible for implementing new interventions and new capabilities to manage a population. And then finally, to provide a forum to exchange leading practices, again, to continue to support that implementation and iteration of those capabilities. You can see the areas of focus down at the bottom of the slide. Again, I won't belabor it, but just know that we are very much a member-driven organization. In a moment, you'll see the various topics that we're aiming to focus on initially, but that continues to iterate as we get new input and new understanding of what our members' needs and goals are. In terms of the deliverables, as I mentioned, it's really a five-pronged approach. And you can see here the one-on-one support includes an annual on-site assessment. Generally, the first assessment that we would put in place is a Medicaid, uninsured, and underinsured population readiness assessment. But we also have a number of other assessments that we can leverage with your organization, ranging from care management functionality, alignment and working with post-acute care providers, transitions of care, patient-centered medical home models, preparation and readiness for two-sided risk, et cetera. In addition, through the collaborative, we offer a number of cohorts that I mentioned previously. So we have the Medicaid uninsured and uninsured cohort that will meet every other month with telephonic webinars, and we'll also have certain in-person meetings. And then we also offer a cohort focused on employee health or the quality payment program, or if you're interested in applying for a Medicare ACO model. Next is the learning exchange and peer networking. So we have a number of in-person meetings that we offer as well. So at least 2 national meetings per year where we bring together everyone within the Essential Hospitals Value-Based Care Collaborative, the Population Health Management Value-Based Care Collaborative, as well as our Bundle Payment Collaborative to really share learnings, best practices, worst practices, which are often great learning opportunities, and to bring in outside subject matter experts and policy leaders. We have an innovation library that's available on our online community, which everyone within the collaborative has access to, where we not only have the library, but we also archive all the materials, the webinars, recordings, the slide decks, the tools and templates that I mentioned previously. I talked about the access to subject matter expertise. Through the collaborative, you're able to work with us. And then finally, the ability to drive insight, scale, and innovation. So working together to develop new value-based arrangements, or to look at how to align your interests with other organizations to develop new approaches. And then, as I mentioned, our goal is to eventually leverage the collaborative to begin to take in claims data from the Medicaid space, and then in the interim, consider what other opportunities there are to bring in data to benchmark us and to drive performance improvement. I did mention the Medicaid population health gap assessment. This is something, again, that's available to you annually. You'll get a report at the end of the assessment that provides you with our thoughts around where you maybe have leading practices that you might want to spread more broadly within your organization, where you have opportunities to drive improvement, a prioritized list of those opportunities, and then recommendations to address them, and really try to focus your efforts on the areas that are going to give you, again, the greatest return on your investment of time and resources. And then finally, looking at some of the curriculum ideas that we've outlined for the Medicaid uninsured and uninsured cohort that's a part of the collaborative. You can see there's a focus on care management and coordination for high utilizers, financial modeling and contracting strategies, funding mechanisms, implications of federal policy changes, moving towards consumer-driven Medicaid plans, like is going on in Indiana, and considerations tied to that, trying to anticipate some of the changes that may be coming in the future, leveraging social determinants of health to understand how to wrap those into clinical pathways and to manage those populations, and then cost reduction methodologies, both internal in terms of generating margin, as well as external costs for those vulnerable populations. So this next slide shows you the current members of Premier's Population Health Collaborative, Population Health Management Collaborative. Those with the red dot are current members of our Medicaid cohort, which again is available to members of the Essential Hospitals Value-Based Care Collaborative. A lot of great organizations, some that are doing some very leading edge work. So we'd love to have you come and learn and share what's going on with your organization, what you found to be helpful, and areas where you've had challenges, and hopefully we can help address those. Just to wrap up, I'll summarize by saying we believe that the collaborative and that three-pronged approach of connecting data, connecting knowledge, and connecting people is really critical, and has been able to help avail our members to being successful really across population health and value-based purchasing programs. We often use the Medicare ACO program as an example. And the reason being is that, getting consistent data from the Medicaid space or from commercial payers or even really the Medicare Advantage space around outcomes is very, very challenging, whereas the Medicare ACO space provides regular, consistent reports on outcomes and performance that uses generally similar methodology. And so what you can see here is in the blue box, the teal colored boxes is the Premier Population Health Collaborative members in comparison to the nation. So our members have outperformed in generating shared savings in the program, so being able to drive greater efficiency into the models. They've also been able to achieve higher rates of savings. So you can see our members comprise about 6% of all the Medicare ACOs, but we're responsible for 20% of the total savings across the entire program. So I think that that's just, again, reflective and indicative of the performance that you're able, that we work with our members to achieve through organizations that are leading edge and are willing to share what's working for them and what's not in a transparent and collegial manner, leveraging data to really focus and prioritize opportunities, and then leveraging Premier, our subject matter experts, and the archive of incredible knowledge and information that we have on our Premier Connect site. So with that said, if you do have interest, if you'd like to learn more, we'd be more than happy to talk with you. At the end of the presentation, you can see our contact information. Please do reach out to us. We'd love to talk to you and provide some more information. With that said, I will now hand the presentation over to Jessica Lerner. As I mentioned, Jessica is the president and CEO of Community Care Plan, and I just would reiterate that they're an incredible organization that's been doing some really great work over the past 8 to 10 years of managing the uninsured, underinsured, and Medicaid population down in Florida. So Jessica, I'll hand it over to you.
Thank you so much, Seth. This is Jessica Lerner, as you mentioned, and in full transparency, I just want to tell you that I don't normally sound like this, like Kathleen Turner, but I have just started to get my voice back, so I apologize in advance if I crack and my voice sounds a little strange. But nonetheless, I'm excited to share the journey that we have had as Community Care Plan today with you. I plan to talk about who we are and what our current business model is, how we got here, the principles of our success, challenges that we've come across, and lessons that we've learned. So at the end, I look forward to any questions you may have. I think hold on one second. It's trying to move to the next. It's not moving to the next slide. Oh, wait. It's not moving to the next slide. I don't know if I'm clicking on the thumbnail. So Community Care Plan, I'm just going to go ahead. Community Care Plan's mission and vision, I'd like to share. Our mission is driven by our community responsibility to positively impact the health and wellness of those we serve. Our vision is to be the vehicle of population health for Broward County. We're currently located in Broward County, which is Fort Lauderdale, Florida, and we are owned by the 2 safety net hospitals in Broward County, one being Broward Health and the other Memorial Healthcare System 50/50. We actually serve approximately 100,000 lives today. They're in various types of populations. We serve Medicaid recipients in Broward, about 40,000 of them. We serve children with special needs, both Title 19 and Title 21. And there's approximately 28,000 covered lives that are those populations. We also do commercial ASO business for various governmental employees in our region. We cover about 32,000 of those people. We have today about 185.
Excuse me, yes. I think that your slides should be able to move now. You could try it again.
They're not moving. I'm clicking on them and they're not moving. It says I'm the presenter and I see the thumbnails, but they won't click.
So we can just move them for you. So if you just want to give us a little cue to move them, we'll go ahead and move them. I'm not sure what happened.
Okay. If you
Thank
go
you. Sorry about that.
That's okay. The next slide.
Yeah. Next.
And then one more. So the question is, how did we get here? How did we become what's called a Provider Service Network, or for short, PSN? And we have a little bit of a history, and I just want to go through it. In 1998, there was actually a legislative initiative by the then Governor Bush of Florida to come up with an alternative model to an HMO. They came up with Provider Service Network, or PSN. So with that initiative, the 3 large safety net hospitals in South Florida, 2 of which are still our owners, decided to come together and form a PSN and applied for an invitation to negotiate. We were actually awarded the contract, and we became an alternative model, as I mentioned, to a Medicaid HMO. In order to be a PSN, you had to be 51% or greater owned by some type of provider. Could have been a physician, could have been a hospital. In our case, it was a safety net facilities. At that same time, we worked really diligently with our legislative folks to create a preference in the Florida statutes, a PSN preference. And I think this is really key for those in other states, because I'm pretty sure it doesn't exist elsewhere. There was no way we were going to be able to compete on the same level with the large national health plans. And the only way to do that was to give PSNs a little bit of assistance, so that when any invitation to negotiate came out, the PSNs would get some type of preference for applying, because they probably couldn't compete at the same level. But I mean, on a local level they could, but sometimes you need, multi-state results, and we wouldn't have had those. So that PSN preference really helped and has continued to help going forward. In the beginning, we became a PSN in March of 2000. We took a shared savings approach. It was a fee-for-service. The state was paying the claims, and we received an administrative fee for doing so. And if there was shared savings at the end of the day, if you achieved less than the target or did better than the targeted amount, then you would share the savings with the state 50-50. That turned out to work very well for the first 6 years of the program, and by 2006 we had reconciled and we had saved the state over $25 million in savings, probably managing approximately 40,000 lives in total for that 6-year period. It was expensive to build the infrastructure, and I'll talk a little bit more about that later. But Florida continued to try to look at reform models for Medicaid. They actually took what we had done and then mandated that in 2 counties in the state of Florida that they go to this type of model. It was called a reform pilot. It was done in 2008. They chose a rural county and a urban county. Broward happened to be the urban county they chose. So we continued to operate and do well for the next 6 years as a PSN, again, with the same membership. We continued to be fee-for-service as well. In 2014, Florida decided to continue that reform and initiated the managed Medicaid statewide. You had to take risk in the state of Florida if you wanted to continue to be a Medicaid provider or Medicaid plan. So our entity got together, the 3 safety nets that currently were involved, and decided to create a separate company. That was Community Care Plan. Previous to that, we're actually operating as divisions within those 3 health systems. We created Community Care Plan as a non-for-profit LLC. We applied for the ITN, or the invitation to negotiate. We won only in Broward. We did not win in Dade, which is where the third owner was. They decided to not continue, so that's how we ended up with 2 owners today. And I'm going to share with you the results of the first 4.5 years of that contract. And I will share that as of October of last year, they put out another invitation to negotiate, and for another 5-year contract. We were successful in being awarded another 5-year contract, which begins this December through to 2023. Next slide. how did we do this? We operate, and I'll go through this part, the foundations of our success are based on 6 core principles. You can see them listed here. The only thing I will share, because I'm going to go through each one of them next, is that we have them ordered this way for a reason. We have quality and customer service and community ahead of the finance, as you can see, and growth, because that is how we've been able to compete. By focusing all of our efforts in becoming the best, highest quality plan with the best customer service has helped the members choose us. Because again, we are competing with national health plans who, you know, have multi-million-dollar budgets and marketing and campaigns, which we do not. Next slide. So first I'm going to talk about our quality. We decided early on when we won this risk contract in 2014 that we needed to come up and be the best quality plan. We needed to use innovative approaches to ensure that members were receiving their care and then we're actually improving the health care of our population and our community. We used various models like physician quality-based incentive programs to close care gaps. We partnered very heavily with local community agencies, which worked out well because we were able to tap into what our parent hospital systems already have in place. We used text messaging campaigns. At that time, nobody was using that for the Medicaid population. We have customer service alerts. When anyone's calling for our customer service department, we can tell them, oh, by the way, we see that you have a mammogram that is due. Can we help you schedule? Those are just to name a few. With being able to implement those types of quality-based approaches, if you go to the next slide, I can share what that resulted in. There are 6 quality indicators that the state of Florida looks at to determine how well a plan is doing in improving the care of its members. They're broken up into 6 categories. You can see them listed here. You receive up to 5 stars per category based on your quality HEDIS metrics. If you note that the little highlight of 4.33, that's community care plans. We have the highest average number of stars in the state of Florida as of their last report card that came out, and we were really excited. We thought we'd only be the best in Broward because they were only operating with 3 other plans in Broward. But when the numbers came out and the comparisons came out, to be the best in the state when you're being compared against Amerigroup and Aetna and Humana, Sunshine, United, was extremely exciting. And I think that shows that the effort and the grass level roots we took approach to quality in our community and improving the health of our community became very, very evident. So really proud of that. Next slide. We also use a very collaborative approach. We have a C3 team, we call it, which stands for Concierge Care Coordination. So all of our doctor practices are assigned a C3 team, and that C3 team consists of every a representative from every department that you see in this bubble going around the heart. And we talk about all patient cases that are in care management or should be in care management internally, and then we work with the physician team. The care manager is the conduit to the physician practice about their members. I think this also helped us in being able to achieve those quality metrics that I shared in the previous slide. Next one. The other area of focus that we really heavily focused on was customer service. We wanted to be the local plan. We're right here amongst the neighbors who have our plan. We can speak the language. We know the landscape. We know the territory. We're not located in Minneapolis. We are located here. And being owned by the health systems as our parents, that has also helped. We try to give concierge customer service. And if you flip to the next slide, I can give you an idea of how we're doing that. I know it's flipping, but while it's doing that, we answer a tremendous amount of calls on our call center. Last year, we answered 243,000 calls. The goal is to have less than a 3% abandonment rate. That's sort of what NCQA is. We've been operating at a 1.08% abandonment rate. We actually successfully authorized 76,500 authorization requests with an authorization turnaround time of less than 2 days. This type of customer service to our providers and our members help achieve some really high-level satisfaction scores. In addition, we processed over 1 million claims with an average turnaround time of 8 days. This keeps everybody happy. We do monthly provider surveys, but we do a large annual provider satisfaction survey, and we were able to achieve a 98.2% rate of our providers being satisfied with community care plan. They get paid quickly, they get paid accurately, they get paid in an electronic fashion, an EFT if they so choose, so they really appreciate that. We also have achieved a 90th percentile for member satisfaction with their health care according to NCQA. And in Florida, they track complaints through something called the Hub. So our agency for healthcare administration, which administers Medicaid, tracks those. We have the lowest number of Medicaid Hub complaints of all Medicaid plans in Florida every year running that they've had it. Are we not able to move forward with the slides? Okay, keep going. Next slide. The third pillar is community, as I mentioned, and if you flip to the next slide, this is just as a small list. The next slide shows a small list of the community partners that we have worked with locally. We have them come into our organization, share what they do, figure out how we can help each other, so that many of these organizations serve the same Medicaid or uninsured population that we serve. So how can we help each other? What can we learn from each other? How can we reach these people? Because that has been a struggle in terms of contact information, being able to get accurate contact information. And they sometimes have a way of doing that, maybe through a Healthy Start or the public school system, but we do not, and vice versa. So I would highly suggest that if you're a provider-based entity wanting to get into the health plan business, using your community roots and your community partners will be key in your success. Next slide. We've worked very hard with our employees. This is just a little bit about the fact that we've been able to improve our employee satisfaction. We have a wonderful internship program where we actually have had 20 interns come through here. We actually have hired 5 of them, and they're a wonderful resource of new and exciting ideas and innovation, and trust me, technology savvy. It's impressive. Next slide. So the question is, can Medicaid be profitable? I think everyone sometimes is a bit worried that Medicaid may not be a profitable entity or program. You have to keep your administrative fees down, which we have done, and we have, in our current contract, our state mandates that the providers get paid a higher rate than Medicaid. That's getting a little more challenging, but we have been profitable since inception. We've operated on the theory that we're going to spend 90 cents of every dollar on direct health care, because that's our mission, that's our parents' mission, and that only 8 to 9% is spent on administration, and the rest in, I'll call it profit, but I would say, contribution to community. The next slide is going to talk about how we did this. You need to understand when we started this, our average PMPM was $236. It actually dipped down a little bit, and then it had a steady increase. So how did that happen? Because I can tell you it's not by the ACA or the state agency saying, hey, we're going to pay you more money. It's been a fight. If you go to the next slide, in the state of Florida, the populations are risk adjusted. So if you can really focus on your risk scores of your members, which you do get provided by the state agency, you identify members who have high complex conditions, but you may not be any code, any diagnosis, any claim related to them. So it does 2 things. We look on a granular level at the members who have had no service, in a physician's office but are only in the ER. And are they diagnosed properly? We try to get them back into care. We go and have clinicians go to their house if we can't get them to a PCP's office to try to gauge what their health condition is and make sure, A, that they're getting the care they need, they're connected with the provider that they need to get connected to, they understand that they don't have to run to the ER, but additionally that the information and the data is getting to the state so they can be risk scored appropriately. And you will get credit appropriately. We identified, for instance, a number, I would say over 200 members who had severely mental ill diagnosis, but nowhere was that found by the state agency. We were able to find it, bring it to their attention, and all of those people were moved into the appropriate category at the appropriate rate and risk score. This is just this slide shows what our risk scores have grown, and you can see the trend going up since we started doing that back in 2015. Next slide. What is our growth for the future? And go ahead, one more slide. We are now going after, in addition to the straight Medicaid population, there are special need populations in Medicaid that require higher complex care. We are looking to do that for the HIV/AIDS population, the severely mental ill, as I mentioned, and the child welfare program. Additionally, we actually can take the infrastructure we have and do administrative service work for governmental entities and other non-for-profit entities where we could be their TPA for their employee population or for their uninsured population, as many of the essential hospitals have to care for. We have an infrastructure that helps not only our parents, but other safety net facilities locally to pay those providers for seeing those patients who don't have insurance. We are actually going for our NCQA accreditation the month of November. We are currently accredited by AAAHC, but we are going for the NCQA accreditation. And in the future, we're not sure. There's a number of health systems locally in Florida that have now taken a little bit more of an interest in becoming a PSN, and maybe there's an opportunity for all of us to get together and become a statewide PSN where we all operate our regions and maybe have one centralized infrastructure. And who knows, one day maybe there's something called a multi-state PSN, which I would love to see in my lifetime. Lastly, and I want to just mention, I kind of peppered it through, if you go to the next slide, some of the challenges. It is costly to build this infrastructure, so you need to be prepared for that. However, there's some you can buy and some you can build. You might want to buy the IT data analytics. You might want to buy, you have to provide services like behavioral health and transportation and things that are not our core. So we've done that. It's hard, the market share, you constantly have to try to maintain your market share, and you're again competing with those large plans, which is challenging, and the state doesn't make it any easier because the marketing limitations and regulations are extremely tough. In our Medicaid contract with the state, they have a lot of sticks and no carrots. So from the liquidated damage perspective, you can get fined for many a thing, and many of the bigger plans have been fined in the millions. We have been fined very little, thankfully, just for process stuff. I mean, if you don't do something, you might get a $500 or $1,000 fine, but you can also be fined in the state of Florida. For every member who needed a preventative service, like a mammogram, who qualified for that service because of their age or whatnot, gender, and didn't get it, you can get fined approximately, I think it's $100 or $150 per person. Those could be very costly, so we need to be careful depending on what your state is offering. There's a lot of unfunded mandates coming. Florida's pretty progressive. I think it's right behind Texas and maybe California. I think they actually all copy each other's notes and figure out what's the most challenging contract term to put in and then put it in. So that's what we are constantly trying to work with, that the rates aren't going up, but they do give you some unfunded mandates. And last, the more that you save money and show that the state that it doesn't cost as much, every year they come back and reduce the rate a little bit more. So you do become the victim of your success at some point, but it is very cyclical because the rates that they end up issuing do have to be actuarially sound. So you might see these 5-year cycles where the rate is sufficient until maybe the 5th year, then it won't be good in the next year, but then it'll come back. Next slide. So our lessons learned, as I mentioned, do you buy versus build? We learned that you have to buy certain essential departments that you don't want to build yourself or programs, but you do want to keep those in terms of care management perhaps, or utilization management, or that in which touches the member or the provider directly. We learned that healthcare is really local and you can really make a presence using your provider-owned safety net hospital parent to help build your brand and be able to work with your community. We've joined the Health Plan Association that's been proven beneficial. They don't love us because we're owned by providers that they also negotiate with, but in the state of Florida, they've worked with us, and we've been able to benefit by some of the initiatives they've put forth with the state. As I mentioned, quality is key. You're not going to ever win on marketing dollars. We're not going to win on, you know, the size, but you will win on quality over quantity. And lastly, just using your grassroots approach. Being able to say you're local and here's what we can do for you and you could call us and we're just, you know, down the street has helped us tremendously, excuse me, be successful. So I thank you for letting me share that journey with you and apologize for the technical difficulties. And we have answer any questions if you have any.
Thanks, Jessica. We have a few questions for you. The first question is, did you as a hospital-owned plan have to meet insurance capital cash or reserve requirements either in 1998 when it started or in 2008 when it went full risk? If so, how did you come up with the cash?
Yes, we did. It was when we became a risk provider in 2014. When you're fee-for-service, you didn't have to put that up because technically the state is paying the claims. When it became our responsibility and our risk, there is a percentage, I want to say it's like 2%. We actually had to go to our parents and ask for money to fund that. We took an equal amount for both, put it into the fund as a restricted account, so that covered it. Recognize the first month you get capitation, you probably get that same amount back, but nonetheless, after about 18 months, we were able to return the initial money we had borrowed from our parents and approximately, I want to say, let me figure that out, 12% return. So yes, we did. You have to have the commitment from your parents to at least invest that capital amount to get it started.
Thank you. Okay, our next question is, did you have to be licensed as a health insurance company by the state health insurance regulator?
So in the state of Florida, you do not have to be an HMO or any other type of licensed entity. It's a little wonky, to be honest with you. You just have to show that you are 51% or greater owned by some type of health provider, and you will be deemed a PSN. Not sure how that works or if that even is applicable in other states, but you did not need an HMO license or any other license issued by like the insurance regulator or the insurance Office of Insurance.
Okay, thank you. Okay, next question is, how does Florida assign new members to Medicaid plans? Is it everyone in Broward in Medicaid is in your plan?
Okay, no. So Florida is sectioned into 11 regions by the state, and we are Region 10 of those 11. There are 4 plans operating as a Medicaid plan in Broward because the statute in our Florida statute says that Broward will have no more than 4 plans, and at least one of them should be a PSN. That's that PSN preference I mentioned. That exists in every region in the state of Florida, but at different numbers. Dade, for instance, Region 11, is much more populated. and they can have, I think it's up to 9 plans, of which 2 must be a PSN. So it differs based on the region in Florida. So we are operating today. Our competitors are Humana, Sunshine, Simply, and us. And how the members choose is they can either actively choose, which you don't generally see a Medicaid recipient actively choosing a plan, or they're mandatorily assigned by the state, and that mandatory assignment is like on a round robin. So 1 out of every 4 who didn't make a choice will get community care plan.
Thanks. So the next question is, did you receive any outside startup funds for the PSN to cover the high upfront costs?
And the only, no. All we did is we kind of calculated how much this was going to cost. We knew what the reserves were going to be. We knew how much it was going to be to operate and have a building and all of those, fixed costs. And we went to our parents and we asked them, can we, do you believe in this investment? Let's build this infrastructure. We had already, remember, been sort of operating on a fee-for-service basis. So we already had a population we were serving of Medicaid. We just weren't at risk for them. So it wasn't like out of the blue. So they gave us, I think it was around $10 million to start this up. As I mentioned, we paid them back within the first 18 months, which is very doable in a new Medicaid contract. If I were going to make a recommendation to someone who's not in this, I wouldn't start in a risk. I would start with talking to your state and see if you could do a fee-for-service model first, that you don't really have to come up with those reserves or need the same level of infrastructure, and then build into whether you want to do a risk arrangement.
Thank you. The next question is, can you say more about the grassroots top health approach?
So, yes, we have identified probably 30 key agencies in the community that we now meet with regularly. We have a medical director of population health and a nurse of population health who actually go out and meet with each of those agencies, and we figure out how we can work together. So an example, one of the things in the state of Florida that's most interesting is you have to close the care gap for children between the ages of 12 and 19 to have their annual visit. Yet the school system does not require any kind of annual health exam to get into school after like the 7th grade. So how do you do that? So we actually have gone to the schools, worked with the schools to try to help us put something legislatively about this, but 2, a lot of these children are getting sports physicals. So how can we have the sports physical add a few more things that will count towards them getting their full annual visit? And we can only do that by working with, the agencies, for the sports agencies, number one. We work with churches and with various faith-based groups who have a lot of children when they're parents, and we're trying to get those people to be advocates for the same cause. So that helps us close some of those care gaps. Another one is the local fraternities, minority fraternities, also allow people in their fraternity, well, maybe you should make them have a physical. And so now we're working with them to try to have that. So when I say grassroots population health, it's being able to get to the people who know best, who have some interaction with the population you're trying to improve the care on, and work out arrangements that serves you both.
Thanks. So the last question that we have is, can you elaborate on if or how you engage community-based organizations to impact the patient population and drive VBP change, transportation, food insecurity, et cetera?
So I'm not sure I heard the whole question. Say that again.
Okay. So the question is, can you elaborate on if or how you engaged community-based organizations to impact the patient population and drive VBP change, for example, transportation, food insecurity, et cetera?
So yes, I think that sort of falls also under our population health. We do a lot for social determinants to work with members who, let's say, you know, might be diabetic but have other social issues, number one. So we're trying to use the community, let's see, we have a transportation vendor that we use that we know that this person has a challenge getting to the doctor or whatever. We have asked them or relied on them. I don't know if we've incentivized them to do it, but we've put them and connected the member with that other type of service to ensure that, you know, whatever health needs they have are being met. I'm not sure I've done any straight value-based programs that, you know, I don't know if we're talking financial or just in a value perspective, but, you know, we're working with, I'll give you another example, clinicians who are going to the home to care for members to at least do their blood pressure or check on their, whatever their condition might be, their hemoglobin A1C, do, you know, some biometrics, so because they can't get to the doctor for whatever reason. So, you know, that's another initiative, and we have actually, to that entity, to that vendor, we've said, listen, go out there, that's great, but if you make sure they get to their PCP within 1 week, we'll give you additional dollars for doing so. Or if you make sure that they stay out of the ER for the next however long, we'll give you additional dollars for doing so. So we are sort of, I guess, incentivizing that to ensure that the member's getting the care and is following up appropriately, and there is some, you know, incentive for that to that vendor.
Thanks, Jessica. And thank you, Seth, as well. So with that, we'll conclude today's webinar. Please look out for an email from us shortly after the conclusion of this webinar. That email will contain an evaluation link that we ask you to complete to help us better serve you in the future for webinars. It will also contain a link to the place on our website where you can access the webcast recording and the corresponding materials from today's presentation. Again, those materials will be available on our website tomorrow morning. Thank you again to our speakers, and you all enjoy the rest of your day.